Welcome to Learn from the Case. Hello, how are you? I opened this channel to present some cases. I work within neurology and internal medicine, and I want to share a little of what I have and am learning. I want to comment that I work in different hospitals in different countries. I also train in different countries, so that treatments in different administrations can and will vary. It seems to me that this also helps us, contributes to our medical training. Today I'm going to talk about juvenile myoclonic epilepsy, the importance to make disease-specific questions to get to diagnosis. A 16-year-old male present to a hospital with repeat transient loss of consciousness, lasting less than 10 minutes. After regaining consciousness, he experienced no disorientation, confusion, tongue biting, or incontinence. Physical findings, blood test, electrocardiogram, and echocardiogram showed no obvious abnormalities. Juvenile myoclonic epilepsy is a common form of generalized epilepsy that occurs in otherwise healthy adolescents. It's a triad of myoclonic of impaired consciousness due to first epileptic seizure in children is 10 to 20 minutes following seizure are reported to occur in 51 to 85% of patients. Most posictal symptoms, including headache, confusion, and paresis, improve within 1 day. In this report, it is described a case of juvenile myoclonic epilepsy in which it was initially suspected syncope because of the short loss of consciousness and absence of posictal symptoms. There are many similar reports like this one on the internet and literature. You'll see that a history of characteristic myoclonic shock led to the diagnosis of juvenile myoclonic epilepsy. A previously healthy 16-year-old male patient with no perinatal or developmental problems presents to a hospital for transient loss of consciousness. 20 days before his visit, he experienced sudden loss of consciousness at the station on his way to school. He recovered consciousness in about 5 minutes and was able to go to school as usual. He experienced no signs of disorientation, confusion, tongue biting, incontinence, or paralysis after loss of consciousness. He visited a community clinic later that day. Some days or maybe a week after that, he experienced brief nausea and a new loss of consciousness for less than 10 minutes, again at the station. The time given here is highly unclear. It's most based on common sense, since he was practically alone when it happened and people around wasn't paying attention to the clock when they assisted him. But it was definitely less than 10 minutes. After regaining consciousness, he experienced no posictal symptoms and was able to walk home unaided. He was subsequently referred to the neurologist for evaluation. At the neurology clinic, the patient said he had been taking ibuprofen once a month for mild headaches and had never experienced chest pain, palpitation, or dyspnea. He showed no edema, weight gain or loss, bruises, obvious physical or neurological abnormalities, or orthostatic hypotension. Blood tests indicate no abnormalities either. A chest X-ray, electrocardiogram, and echocardiogram showed no abnormalities. When he returned 10 days after the initial visit, it was inquired if he had experienced any sudden involuntary body movement to confirm the presence of myoclonic shocks. He stated that he had occasionally experienced sudden movements of his legs while taking a class or operating his cell phone. That the movements appeared at least once a month, like the headache, but not always at the same time, and that the sudden movement had occurred at least 4 times so far. Based on the patient's age and the history of characteristic myoclonic shocks, it was considered juvenile myoclonic epilepsy to be the primary differential diagnosis, and obtained an electroencephalogram, which showed diffuse bilateral bursts and spike and wave complexes, leading to a definitive diagnosis. He consulted an epilepsy specialist, and after taking an initial dose of lamotrigine 25 mg a day, which was later increased to 100 mg a day, the myoclonic shocks disappeared, and no recurrence of loss of consciousness was observed for more than 2 years. Cases like this one leaves us with 2 important conclusions. First, in adolescents with transient loss of consciousness, especially when seizures are likely, juvenile myoclonic epilepsy should be suspected, and the presence of myoclonic shocks should be confirmed. Although the first generalized tonic-clonic seizure in juvenile myoclonic epilepsy is often preceded by myoclonic shocks for several months to several years, patients typically visit a physician after their first generalized tonic-clonic seizure and usually report only the seizure. Therefore, medical providers should actively suspect juvenile myoclonic epilepsy and specifically inquire about it. Myoclonic shocks reportedly occurs most frequently after morning, after awakening, after naps, and intermediate awakenings during the night, although myoclonic shocks do not necessarily indicate certain disease. When examining a patient with impaired consciousness of suspect epilepsy, the specific question, have you experienced any sudden involuntary movements and drop things as a result, can facilitate the diagnosis of juvenile myoclonic epilepsy. Patients with juvenile myoclonic epilepsy generally respond rapidly and completely to broad-spectrum antiepileptic drugs, such as valproate or lamotrigine. Thus, prompt diagnosis and early treatment can avoid accident caused by loss of consciousness and improve the daily lives in adolescents. In many cases, valproic acid is the first-line drug because of its efficacy in treating seizure and its low cost. However, it is teratogenic, and other agents such as lamotrigine or levetiracetam might be recommended in post-pubertal women. In this case, the appropriate treatments were discussed with the patient and mother, and then it was chosen to use lamotrigine. The second important conclusion that this case gives us is that as syncope and seizures cannot be distinguished purely based on the patient's history, seizures must be considered even if loss of consciousness is transient or present without subsequent disorientation or confusion. Of course, is much more rewarding, and because of that desire that a witness is present when a person passed out, even when this witness does not always have much more idea of how much time or how many exact minutes the unconsciousness lasted. Information they provide help us a lot, and they help the person during the episode also. Exclusion of seizures is even harder in cases with a self-report disoriented state, because the diagnostic accuracy decreased significantly. To differentiate seizures from syncope, the diagnostic approach should become multiple findings, rather than being potentially confused by the vagaries of posictal symptoms, especially if the patient self-reports them. In conclusion, seizures cannot be ruled out in patients with transient loss of consciousness, even if the episodes are short or do not involve disorientation or confusion, especially when the information is self-report. In adolescent patients, juvenile myoclonic epilepsy should be considered in the differential diagnosis, and primary care physicians should actively and specifically investigate the presence of myoclonic shocks. Now I would like to remind a couple of things about this kind of epilepsy and the EEG. Directly it comes to my mind, this is about the area of the cortex that need to be involved to see the seizure activity with EEG. Do you remember? 6 square centimeters or more. This is for the scalp or traditional EEG. The invasive EEG will not be discussed now. As a rule, in any patient with a depressed level of consciousness, with or without neurological problems, non-convulsive status epilepticus should be on the differential. Non-convulsive status epilepticus is treatable, but if it goes without treatment, can go to obtundation or coma, and then it becomes much more complicated. Non-convulsive status epilepticus can occur after convulsive status epilepticus, so it's critical to try to observe those patients that underwent status epilepticus with an EEG. Any individual who has had clinical seizures and is not back to baseline should be connected to video electroencephalogram when it is available. Unequivocal electrographic seizures are defined as generalized or focal spike wave discharge at 3 Hz or faster, and clearly involving discharges of any type that reach a frequency of more than 4 Hz, whether generalized or focal. Juvenile myoclonic epilepsy is usually diagnosed between 8 and 25 years old, women and men equally affected. Myoclonic seizures appear often in the morning or after a nap, can have generalized tonic-clonic convulsions and absence. Neurologically normal patients, easy to treat, responds well to antiepileptic drugs, but usually requires lifelong medication. In EEG, when you're lucky and can catch seizure activity, you'll see normal background. Interictally, majority will have 4 to 6 Hz generalized polyspikes and spikes discharges. It is also possible, even when rare, that a person develops juvenile myoclonic epilepsy without dramatic clinic symptoms, and his or her life goes on without knowing of the juvenile myoclonic epilepsy until something more evident comes along. Juvenile myoclonic epilepsy constitutes 5 to 10% of idiopathic generalized epileptic syndromes. The clinical triad of absent seizure, myoclonic shocks, and generalized tonic-clonic seizure rarely begin after the second decade of life. I find a case that presents in internet. Here I leave the link so you can read it also by yourself. It's the case of a 74-year-old lady presenting for the first time with myoclonic shocks and absence. The electroencephalogram revealed it generalized polyspike and wave epileptiform activity with photosensitivity. On close questioning, she appeared to have had a single episode of generalized tonic-clonic seizure at the age of 10. She remained asymptomatic for 74 years before the diagnosis was made, or at least seems to be so. Although rare, idiopathic myoclonic epilepsy could remain asymptomatic for decades and can present in the elderly. Proper classification of this epileptic syndrome, even in the elderly, is essential in view of the response to appropriate anti-epileptic therapy. Here another website. Observations in the epilepsy outpatients clinic suggested that juvenile myoclonic epilepsy patients older than 40 years of age are rare, without diagnosis as it means. There are a few anecdotal case reports of juvenile myoclonic epilepsy in old age. Although rare, idiopathic myoclonic epilepsy could remain asymptomatic for decades and can present in the elderly. The abstract here says juvenile myoclonic epilepsy is an idiopathic age-related generalized epileptic syndrome. Status epilepticus in juvenile myoclonic epilepsy is very rare and little is known about its etiology. We report 2 cases of adult patients retrospectively diagnosed as juvenile myoclonic epilepsy by non-convulsive status epilepticus, which occurred for the first time. One patient was a 52-year-old woman who has present with confusion and brief generalized tonic-clonic seizure for the first time. The other patient, a 39-year-old woman, visited the ER with transient loss of consciousness following confused mental state. Electroencephalograms of both patients, respectively, showed generalized polyspike and slow waves which were disappeared after IV injection of lorazepam. With careful history taken, both of them, the patients were diagnosed as juvenile myoclonic epilepsy, and the seizures stopped just after sodium valproate medication. Non-convulsive status epilepticus in patients with juvenile myoclonic epilepsy is rare, but detailed history taking and suspicion of the disorder is helpful for diagnosis. This last one, as you see, also talk about another unusual topic, status epilepticus in patients with juvenile myoclonic epilepsy. The anamnesis, EEG, and response to antiepileptic drugs are important tools that we can count on. I hope this video has caught your attention. This presentation is entertainment for students and health professionals who want to listen to studies, discussions, or clinical cases. It is not intent in any way to replace the learning provided by reading medical literature or the experience provided by clinical practice.